Good morning, everyone. I'm Angie Valeka. I am the program manager for heart and lung transplant at Cedars-Sinai in Los Angeles. We're very excited to have you here. I guess I should say good morning for me, but good afternoon for some of you, and good evening for some others, as we have colleagues joining us from around the world. So this is very exciting. So today, our topic is Everything, Everywhere, All at Once, current trends in transplant nursing and allied health. And the discussions are going to include management of resources, professional career development, and evolving trends in program development and onboarding. We have two great moderators. I'm proud to introduce Anna Forsberg from Lund, Sweden, and Dawn Eck from Vanderbilt Transplant Center in Nashville, Tennessee. So they're going to lead our different topics that we have presenting today, and Dawn's going to start us out. So Dawn began her nursing career as an advanced practice provider with Vanderbilt's heart transplant program. Over 20 years ago, the program grew from 12 transplants per year to now over 100 transplants annually. And then Dawn became the director of thoracic transplant in 2018 and currently supports 4 clinical groups: heart transplant, lung transplant, organ recovery, and organ preservation. So Dawn, please take it away and introduce our first topic.
Sure. Thank you so much, Angie. So we are excited to have our first session entitled Goodwill Hunting, and this is going to focus on clinical ladders. And this is a very hot topic across nursing and also across the transplant community. So we're excited for these talks today. We all know that clinical ladders are a great tool for recognizing high performers and increasing employee engagement and employee satisfaction and job satisfaction. So Megan Keating and Annette Needham are our speakers for this session. Megan is a pediatric nurse practitioner with the heart failure and transplant team at UCSF. Megan has experience in heart failure, heart transplant, cardiothoracic surgery, and she had that experience before joining UCSF in 2017 as their first NP on the pediatric heart transplant team. And she played a key role in developing that program, which performed its first pediatric heart transplant in 2018. And more recently, the program achieved their CMS designation as a pediatric heart transplant center, which is a huge milestone. Annette is a quality nurse manager from UC Davis Transplant Center, and she's been in transplantation for 26 years with experience in kidney, liver, heart, and living donor transplantation as well as administration. And part of her experience also includes developing new organ programs. So we're thrilled to have them both. And Megan, I'm going to turn it over to you to get started.
Great. Thank you so much for that introduction. Today, I'm going to be speaking on Goodwill Hunting, engagement through transplant coordinator and advanced practice provider professional development. Specifically, I'm going to be talking about development of the nurse practitioner career ladder here at UCSF. At UCSF, we're based in San Francisco. We're an academic medical center focused on patient care, research, and education. We operate multiple campuses, 600 beds at the main hospital and 289 beds at Mission Bay, where pediatrics is based. We performed over 20,000 solid organ transplants, including heart, lung, kidney, liver, and pancreas. And we have 574 career nurse practitioners currently across our campuses. Our current clinical ladder for nurse practitioners was developed in 2015, which I'm going to be talking a little bit more about today. This is our current clinical ladder for nurse practitioners. So it consists of NP1, which are new graduate NPs with less than 6 months experience. NP2s are nurse practitioners with more than 6 months of experience. And this is really what most positions are hired at. And then NP3, which is considered a clinical expert, someone that develops excellence that demonstrates excellence through advanced practice clinical education, as well as leadership. And looking at the history of the NP3 role, so prior to 2015, there were 6 legacy NP3s in the UCSF health system. There was a pay code job title that was different from NP2s, but there was no NP3 job description. And then in 2015, UCSF leadership founded an NP3 committee, and they developed the NP3 job description. They identified contributions necessary for the NP3 role, and they implemented a review process, which I'll talk more about. We're part of the union here at UCSF, so the CNA was made aware of the new clinical ladder system and given the opportunity to provide comments as well. Minimum qualifications for the NP3 role here at UCSF include current license, 4 years of experience as a nurse practitioner, 2 years of experience in current clinical specialty at UCSF, a minimum appointment of 0.6 FTE. So unfortunately, per diem NPs are not eligible for the NP3 role, and current overall performance evaluation of meets and exceeds or above. The application process, having gone through it a few years ago, I can say it's quite time consuming. It includes a CV, personal essay, which is 250 to 1,000 words, and really describes your leadership trajectory, gives you the opportunity to elaborate on leadership activities, and also talk about future plans for leadership in the NP3 role. A performance evaluation within 12 months, leadership activities, which I'll talk more about, 30 CEUs within 24 months, and then a panel interview, which consists of the NP3 committee, which includes NP3s, as well as the director of advanced practice at UCSF. This is an example of the leadership activity form. So it requires completion of 6 activities within at least 3 separate categories within the past 24 months. Here are some examples of transplant-specific leadership activities, such as staff training in accordance with CMS requirements, School of Nursing lectures on transplant-specific topics, quality improvement projects. I recently worked on a TAC quality improvement project to decrease the number of TAC medication errors within the pediatric CICU. Order set development, protocol development, as well as serving as chairs of various NP committees, including an education committee. This is an example of the application. We do include an example application, which can be helpful for new applicants, as well as the job description and the application itself. There's no limit on the number of applicants that are successfully granted the NP title per year. Appointments are for 3 years and include a 5% raise. The application cycle is twice per year, and 3 months prior to expiration of appointment, NP3s must submit a re-application. Overall, our numbers are growing. So in 2015, there were 11 NP3s. Currently, there are 90 NP3s within the UCSF health system. There have been 20 cohorts to date. Applications are due in September as well as March. In 2025, 16% of the 574 career NPs were in the NP3 role. And in 2025, 11% of all the NP3s were part of either the adult or pediatric solid organ transplant program. So why build this bridge? The International Transplant Nurses Society does emphasize development of the APP role with advanced clinical expertise, leadership and collaboration, as well as research and evidence-based practice. We know that professional development opportunities are really important in achieving professional fulfillment for APPs. And then there's a really nice study out of Stanford that looked at implementation of a career ladder and showed that a career ladder can improve engagement and retention. And ultimately, we know that improved APP job satisfaction can positively impact the quality and safety of patient care. Thank you so much. I'm happy to answer any questions at the end of the chat. Also, if you have any questions, feel free to contact me. Here's my email address.
Megan, thank you so much. And thank you for the reminder. We are going to hold questions until the end, until all 4 speakers have shared their presentations. And then we'll have dedicated time at the end. So hold on to those questions. So Annette is next, and so she will continue this session on clinical ladders.
Hi. Thank you, everyone. Good morning or afternoon. I'm going to do part 2 of this Goodwill Hunting. So I am in Sacramento, California, which is just a few hours away from Megan at UCSF. And we also have a bridge. It's a lot smaller. This is the Tower Bridge, which was painted gold to match our state capital. So UC Davis Health is in Sacramento, California. We're a 651-bed multi-specialty academic medical center and the only level 1 trauma center in inland Northern California. We are a magnet designated facility, and we also have the University of California, Davis, which is a medical school, veterinary school, has agriculture, viticulture, and a huge arboretum. We have more than 350 advanced practice providers at UC Davis, and we also have a school, the Betty Irene Moore School of Nursing, which has 4 graduate degree programs, PhD, DNP, physician assistant, and master's. So looking at UC Davis Health and our transplant center classifications, so we do have, as Megan does, a nurse practitioner, which is very similar. 1 is entry, 2 is above 1 year, and 3 is achieved by a clinical ladder. We also have registered nurses that have a ladder, very similar to above with their numbers. And then for Transplant Center, we actually developed a new classification called Transplant Coordinator 1 through 3. And it's a very similar where 1 would be entry level, 2 is experienced RNs in transplant, and then 3 is reserved only for NPs and lead RNs. So just a little bit about our center, we have a total of 15 Transplant Coordinator 2s, plus 2 RNs that work as living donor advocate kind of case managers. We have 15 Transplant Coordinator 3s, 2 of them are RNs leads. We have 5 NPs outpatient and 6 NPs inpatient, and then 1 NP in dialysis access and 1 in hepatology, both outpatient. So just to give you an idea of the size of our program, we do around 300 to 350 kidneys a year, 65 to 75 of those are living donor. We have a liver program, which is around 50 to 70 per year, and we just opened our living donor liver program, no patients yet, and our heart transplant is pending opening. So we're very similar to UCSF as far as a career ladder for the NPs. We have an application process, points rewarded, there's a review board. There is no ladder currently for transplant coordinators. The TC2 must obtain an NP or a lead position to move up to a TC3. And TC3s are actually at the top of the classification. So if they're hired into that level, they have no movement up. We don't have a TC4. So we're feeling like there's no incentive to grow professionally, and the transplant certification is already lacking for advanced practice providers. So we developed a ladder for transplant coordinators. We used the current UC Davis clinical ladder as a base, and we swapped out elements for transplant-specific tasks and achievements. We aligned this with the ITNS social society ladder, and we did send it to our union for review. Our staff were informed we were doing this before we sent it. Unfortunately, there was a huge communication issue, and they mistakenly thought it was a mandatory thing we were going to make them all do, and they filed a grievance with the union against us, and we did receive a cease and desist letter. It's a sad story. Here is what we looked at for to develop the clinical ladder. This is the ITNS page. And we also use NACCO core competencies for both coordinator and advanced practice professional. And we came out with a rubric so that they could score on 3 different areas of professional development, leadership, and education. So in conclusion, for our story, we do not have a clinical ladder for transplant coordinators at UC Davis. We do know that a similar clinical ladder is being used at other transplant centers. I have been willingly sharing this on different listservs and with colleagues so they can take advantage of it. We did actually get support from our chief nursing officer once we received that cease and desist. Unfortunately, he did move on, so we were going to have to seek new support. And we've been having management discussion on best strategies to move forward. Should we create a TC4 classification? Should we think about doing a stipend type of structure instead? And definitely we need to do some engagement with our current coordinators. Thank you.
Annette, thank you so much. So I'm excited for all of the questions because I know there will be several. So at this point, I'm going to hand it back over to Angie to introduce part 2.
Thank you, Dawn. Actually, I am excited to introduce our next moderator for the next 2 presentations we have. Anna Forsberg is a registered nurse with over 30 years of experience in organ donation and transplantation, both in clinical care and research. She became the clinical professor in caring sciences, specializing in organ transplantation in 2013 at the Lund University. And Anna serves as the PI of the Swedish multi-center study Self-Management After Thoracic Transplantation. And she has more than 100 scientific publications focusing on transplantation and organ donation. So Anna, please introduce our next topic and our next 2 speakers. Thank you. We're happy to have you.
Thank you. It's a pleasure. I'm in Sweden, so it's evening in my country. But it is an honor and a pleasure to be here and to listen to all these inspiring presentations and these very ambitious programs that you have. The next session, called Training Day, we will discuss sharing best practices and onboarding transplant professionals. And we have 2 speakers, Eleanor Johnson and Paul Schenk. And we start with Eleanor Johnson, and she is from University Hospitals in Birmingham in the UK. And she is a senior heart and lung transplant coordinator and a non-medical prescriber at the Queen Elizabeth Hospital in Birmingham. She's also a national specialist advisor for the NHS England program in improving mortality and outcomes post cardiothoracic transplant. We are very happy to have you, Ellie, and the floor is yours.
Good evening, everybody. Likewise, I'm in the UK, so it's evening time for me. Thank you very much for the introduction. My name is Ellie. I'm one of the transplant coordinators here in Birmingham in the UK. To start off my presentation, I thought I would give a bit of insight into how things work here in the UK. We work off a national health system with the input of the NHS Blood and Transplant Society. Within the UK, there are 6 adult transplant hospitals and 2 paediatric hospitals spread throughout the UK, as you can see on that graph there. For a bit of an additional UK insight, I'm now going to share some slides that give you a snapshot into transplant numbers over the last 10 years here in the UK. So starting with heart transplants, the graph here demonstrates the heart transplants that have been performed over the last 10 years, with an expected dip in 2020 during the COVID pandemic. We can then see some steady growth since, which has continued to grow to an even grander scale these last 12 months. Unfortunately, that won't be published until next year, but we're hoping that the 2024 to 2025 figures will be even better than those last year. This then is broken down a little further into the heart transplants that have been performed here in the UK over the last 12 months per centre. And then again, moving on to the lung transplants over the last 10 years, smaller volume than the heart transplants. The expected dip in 2020 during the COVID pandemic. We have faced a more, it has been more of a challenge to recover from COVID in a lung transplant aspect, but we are getting there. And again, over the last 12 months, we've seen really encouraging progress in the number of transplants that have been performed. So hopefully those figures that are published next year will be even more promising. Again, a breakdown of lung transplants within the UK by centre over the last 12 months on that slide there. So moving back to training and how the transplant centres work here in the UK. What makes a UK transplant team? As with most transplant centres, the team is split through a whole host of multidisciplinary team members ranging from nurses, doctors, surgeons to all aspects of the allied health professional world, which is of course driven by those dedicated and hardworking transplant coordinators that we're now going to break down in a bit more detail. So in the UK, nursing is run through a banded pay scale. When you first qualify as a registered nurse, you start at a band 5 level. As you progress through your career, one would usually be promoted to a band 6. And then when people are looking at more specialised role, like transplant nurses, you would be applying to those band 7 positions. And most transplant coordinators within the UK sit at that level on the pay scale. Every transplant coordinator will begin their career by obtaining a degree in either adult or paediatric nursing. Dependent on where their career takes them, and they're looking at applying to those more specific specialised roles such as transplant. There is an expected criteria of experience in the field of cardiology, respiratory or cardiothoracic surgery. And then the desirable criteria for a transplant coordinator would also include exposure to the transplant pathway in some way, and some form of postgraduate learning that is usually up to or including a master's level. When somebody is employed as a transplant nurse, they will start as a band 6 with competency-based progression up to a band 7. So here in Birmingham, for a bit of a breakdown, our team consists of 10 full-time transplant nurses. We have a lead transplant coordinator that has general oversight of the whole team and manages us all. We then have 4 senior transplant coordinators co-managing different aspects of the transplant pathway, so assessment, post-heart transplant, post-lung transplant and LVAD. We then have 5 additional transplant coordinators, 2 of which are band 7s, 3 of which are band 6s working towards their band 7 competency. So what is that competency? What does it involve? A lot of our role, as with those throughout the country, is learning on the job. Job training starts through a mentorship program, which is usually set out by a senior transplant nurse, shadowing and supporting a junior nurse as they come through the program. And it's that mentor's responsibility to ensure that new starters are getting exposure to all of the relevant aspects of the role. The competency-based program is usually set out over a 12-month period, and then when somebody is deemed competent in all different areas and aspects of the role, they will be put forward for their band 7 position. In addition to the general competency-based learning, there's always opportunities to develop yourself further in form of postgraduate learning, whether that be in something specific in the care of cardiac patients or respiratory conditions, or in health assessment at a junior doctor level or non-medical prescribing. Those opportunities are also something that are available to most transplant nurses when they get to that level of seniority. We then have many opportunities throughout the UK to be involved in national projects. This includes things like organ utilisation. There's been a lot of work into organ utilisation over the last 12 months with various programmes and work streams set up that many of our coordinators have been involved in. And we believe that this is one of the main reasons behind the increase in transplantation we've seen this year. There's also lots of collaboration and shared learning forums amongst the transplant centres, so opportunities for specialist nurses to come together, discuss their practices, learn from each other, share experiences, and we have a really good open forum with that is led by the transplant nurses and has a generally really good turnout every few months that we meet. There's then national a development such as the British Transplant Society Annual Congress, which runs once a year and is an opportunity for clinicians and allied health professionals to come together to discuss best practices and learn from each other. There's various different national research programs and advancing in technology. And then, of course, international opportunities such as this forum and other European and American projects that we are often involved in. So that's it from me for now. Likewise, we'll thank you very much for your time, and I'll be happy to answer any questions at the end of the meeting.
Thank you, Ellie. Fantastic presentation, and it's also nice to have the European perspective. I realize that there are very different conditions in different countries, and I am engaged mainly in Scandinavia, but also in Europe, and I can see the differences in different countries and the different conditions for nurses to make a career. So thank you for that, and we get back to you. I have been writing down some questions, so we take them afterwards. Okay, I'm happy to present our next speaker, Paul Schenk. You're most welcome, and you are the Senior Nursing Director of the Ambulatory Cardiovascular segment at the University of Michigan. You have 12 years of nursing experience, including medical, surgical, critical care, ambulatory care, and management. And you have also been involved with the adult heart transplant program at Michigan Medicine for the last 4 years and provides direct leadership support to the adult pre and post heart transplant teams. So the floor is yours, Paul. Looking forward to your presentation.
Thank you so much, and I really appreciate this opportunity. So like she said, my name is Paul Schenk, and today I'm going to be talking about training day and sharing the best practices and onboarding for transplant professionals. So as I was preparing for this presentation, I was thinking to myself, what makes a orientation and onboarding process good? And the bottom line answer that I came up with is that it takes whatever the staff need to make a successful onboarding process. So I asked my staff, what are the things that they thought made them successful in their role, and how could we improve our orientation and onboarding process? And so I got a lot of themes that I'd like to cover. The first and biggest one that they expressed was that there was a desire for clear expectations of what's going to be expected of them. And that's expected from leadership, and as well as what's expected from coworkers and providers in the program. They also desired a lot of leadership support with frequent check-ins to see what is needed to help them progress through their orientation. Another one that they consistently referenced was time, and deciding that they didn't want to feel that they were being rushed through an orientation. And that goes into the next one of understanding the why. They felt that it was really important to understand why certain workflows and pathways were the way that they are, so that they can really get a good insight into how it is that they need to do what they're supposed to be doing. Another area was relationship building. And I think that this is really important because, as we know, our health systems are extremely complex. And it takes a lot of relationships, not just within the team, but with ancillary services, with a various number of providers, both inpatient and outpatient, to make a successful transplant program. So spending some time with that relationship building is really important. And then there was a lot of reference about policies and guidelines. The staff really indicated that having clear policies and guidelines that they can reference is vital to the success of an orientation. And then the item here in the center is one that was really expressed as what they felt has made them successful in the program, and that was mentorship. We have a lot of senior nurses in our area, and those nurses really provide a lot of mentorship, helping our new hires along and developing them to be expert nurses. So, and I know a lot of people are probably familiar with Benner's novice to expert model, but I wanted to root this conversation in some nursing theory. And while I know that it's dorky, I really do subscribe to this theory. And I want to take a second to go over it. And basically what this says is that throughout your career, in whatever area you're orienting in, you're going to be progressing from novice to expert. And it takes time, and there's a number of different checkpoints along the way in that progression to expert. So how do we kind of move people through this progression? At the University of Michigan, we're using competency-based orientation. And while this may sound very rudimentary, I would say that the number one question that I get asked as I'm interviewing potential candidates is, how long is the orientation? And my answer really is normally the same and reflects this competency-based orientation that we take as long as we need to in the orientation. And as long as we're making forward progress, we continue with the orientation. But we shouldn't focus on the time that it takes, rather making sure that we're comfortable and competent with each of the tasks that's on the orientation checklist. Using this orientation model rather than a time-based model, it instills a lot more confidence in the staff after orientation. They can feel comfortable that they've seen everything and been engaged in the various different aspects of the role. But not only does it instill confidence in the new orientee, it instills confidence by the team and the providers, knowing that the staff have gone through a rigorous process and have validated competency in all of the aspects. But there are a little bit of downsides to this, and it's very time intensive. I don't know if anybody here has ever tried to create a comprehensive competency for a program, but it is a large undertaking. And I want to highlight that once you create a comprehensive competency, it's not a static document. This document needs to be continually updated as workflows change, as policies change, and as research changes. And I would highly suggest that this document is updated as you're making changes to your practice, because otherwise, when it comes time to onboard your newest staff member, you're going to be utilizing an out-of-date competency, which isn't going to be getting the desired effect out of orientation. It also takes leadership involvement in the orientation to help the staff seek out orientation opportunities. As we know, especially in the transplant world, sometimes there's things that come up that don't always come up and are more of a rarity. And so it's really important to seek out those opportunities and provide that leadership support to allow our staff to step away and gain that competency and exposure in those rare items. So I want to go back to theory, and I think that this is a really important point, and probably my biggest takeaway point is after orientation, it does not mean that our nurses are already, they finished their competency-based orientation and now they are expert nurses. And I want to go back to Ellie's presentation with the different bands, and it takes a long time to be able to progress to that expert level. And so it's important to note that somebody fresh off of orientation is really more in this advanced beginner category and still requires a lot of time and exposure to become an expert. So how do we get from that advanced beginner to the expert stage? Here we use a mentorship programs, and mentorship really highlights that learning is going to continue to occur long after the completion of all the competencies and orientation. It's required because it really builds confidence. That having a senior staff member help to mentor or younger staff member can help to direct interactions and improve the relationship building, like I talked about earlier, with all of the different programs and pieces that we need to work for to have a successful transplant experience for our patient. It also increases staff satisfaction as they have a team member that they can bounce ideas off of, discuss hardships with, and work through their day-to-day that isn't leadership, and it improves staff and patient safety. And I finally here, I wanted to highlight that developing a mentor isn't something that just happens. Developing a mentor takes significant amount of time. We need to be very cautious as to how we are identifying our mentors. And it's not always the most senior staff or a highly clinically competent staff. Mentorship involves a lot of patience and a lot of education of staff members. So really identifying the skills in our workforce. And we need to include this in our goal setting conversations as we're going through our annual evaluation process and really talking to senior staff members about mentorship. And I also want to highlight that the support from mentorship is vital. We need to acknowledge that this mentorship takes a lot of time out of our senior staff members' day, and that it's important for the growth of the program and for what happens when those mentors eventually move on. And so as we're looking at various productivity metrics and assigning various tasks throughout the programs, it's really important to understand who is a mentor so that we make sure that we don't overload and burn out our staff who are volunteering to do this. And then I also want to highlight that we can't be afraid to assign mentorship formally after orientation. Oftentimes, it's really hard for a junior staff member to take that initiative and ask somebody to be a mentor, and pairing them up and just linking them up with somebody who they can ask questions to can go a long way. And so those are really some of the really key points in how we complete a successful orientation at the University of Michigan. And I'm excited to open it up for questions and comments.
Thank you, Paul, for this great presentation. And as you concluded, now is the next phase of this webinar where we will go into the Q&A session. And we are very excited to hear your comments or questions, or if there are any concerns maybe that you have. So please feel free, and you can write the comment in the chat, or you can raise your hand and just post the question. And if you feel comfortable, it would be great if you also turn on the camera so we can see your face when you ask the question. And the first raised hand that I can see is Donna Guadis. Welcome, Donna.
Thank you so much, everyone. Really, really wonderful presentations. I'm very sorry I don't have a camera on my desktop computer, so sorry about that. But I was wondering if anyone on the panel would please answer this question, because this is something I am dealing with right now and have dealt with in the past, and that is retention of staff. We know that, it's very difficult to, get everyone through an orientation, and we all put our time and energy into training. But, it just may not be the right fit. But for someone who seems like they're the right fit for the job, but has some reservations or has, other things, other reasons why they don't want to continue in the role. Can anyone please comment on some of the systems or strategies you've put in place to help retain your staff?
Thank you, Donna. Who would like to answer this question in the panel?
Maybe a few of us, but I can start.
Yes, please.
So we found that the dissatisfaction for our staff was twofold. One, it was being on call and having to do a full-time job also. And the second thing was being hourly. They had a lot of overtime, and at some point, like, the money just wasn't worth the overtime. So we did two things. We did create that transplant coordinator classification. They do get initially at least 5% higher than clinical nurses. So we kind of made them, like Ellie has in the UK, like a specialist nurse. So that felt good to them, in addition to providing them a salary structure. So they can flex their days. If they need to go to the dentist this morning, then tomorrow they might work a little later. You know, they have complete control on their schedules. And then the third thing we did is we contracted with an outside on-call agency, and we took call away from them. So those helped, and we really haven't had turnover. We've had people here for literally 30 years.
I'm sorry, guys. I don't know how to raise my hand. I can't figure it out on Zoom. So my apologies for being technically inept. But I will piggyback onto Annette's comment. And I think that if we went back to the ISHLT, the adult cardiothoracic paper that came out, I think it was in 2015. Two of the things at that time that were stressed was, like, you know, having donor call teams so that coordinators had a manageable workload was one thing. And then the other thing was creating a transplant coordinator professional development ladder. I have to give a lot of kudos to the team through the International Transplant Nursing Society who came up with a template that we could use. And that gave us a lot of force here within our own institution to be able to go to HR and say, you know, this is what is happening in the field, and this is what we should be offering these expert nurses who are carrying this workload. So those two things, I think, definitely made an impact. And to piggyback on to that, you know, when Paul mentioned the competency and the in-depth and the heavy lift that involves, when you have a coordinator that is on call, they need to know pre-transplant, post-transplant, because they take the patient calls, they take everything. So that was an unbelievably heavy lift to get that person onboarded to all those areas as well as on call. So once we could, you know, take that off the table and focus more on, you need to know right now this area that you're working in and know it in depth, and reduce that massive competency packet to something more manageable. I also think that made a difference in onboarding. So I just want to piggyback. I agree with Annette's comments.
Right. And Ellie, you raised your hand also. Do you want to add something?
Yeah, so recruitment and retention, I think, is something that everyone struggles with at various points throughout their team's expenditure. We, for a long time, had a really senior, dependable workforce that consisted of you know, semi-young women that all seemed to go and have babies at the same time, and we became very depleted very quickly, because coming back to such a demanding job with the on-calls is horrible when you've got babies and young children. So we really struggled for a good few years in recruitment of dependable nurses and training them up to a competent level. Some of the things we have changed about our practice through that process is really looking at the selection of suitable candidates. We were insistent in most cases that people came to spend some time with us before applying for the jobs, so that they properly understood what it involved, and we could be really clear in how heavy the burden of on-call can be and what would be expected of them during their time with us. Because through experience where new transplant coordinators did not have that proper insight, they came to the job expecting a bit of an easier ride than they were having on the ward, and actually found that they had no idea what the job involved. And then, despite our time and investment in educating them, they did unfortunately then leave. Something else that we changed throughout that process was how we measured our competency program. Most people, the job advert is put out as a band 7 transplant nurse, so a senior specialised transplant nurse, and people came into that job expecting to get to that level quite quickly. But through our competency-based learning, we spread out the workload over those first 12 months so that they were getting proper time and exposure to each of those areas. And they were then, through that, having to really work for their band 7. So at the end of their year, or when they got to the point at which they became competent, they were so much more invested in what they had achieved and the last 12 months of hard work that they had put in, that, you know, that they were more invested in the specialty, and then through that were passionate and wanted to stay, and those patients that we've dedicated that time to, we've had much better retention with.
Great. Dawn, you raised your hand, and then it's Meg Fregoso, but first Dawn.
I would echo all of the things. I know retention is one of the very highest priorities in everyone's program, because these are such specialized team members, and there's a lot of investment in their onboarding and orientation. So I would echo all of the items previously mentioned, and I would add just at our center, we have leaned way in on shared governance. We have a transplant coordinator council. We have a transplant nurse practitioner council. So those, we have a coordinator-led policy committee, along of course with our quality director, and our patient education committee. So really, really empowering them to just practice at the top of their scope. And that every opportunity, and I know they all of you guys do as well, just keep reminding them how much, how much we value them, and just really, really, trying so hard to engage all of them, and because they're so talented, and we're they have so much to share. So I just wanted to add that piece as well.
Right. Meg, would you like to share your experience with us?
Thank you. Yes, I will echo what Dawn said. I think for our center, when we were able to bring in an outside team to take over our transplant call, that really significantly improved our retention, because we would take call along with running our regular transplant clinic hours, so there wasn't really an opportunity to call out if you were running a transplant all night long. So that certainly has helped. But what we are struggling with is integrating a transplant clinical ladder here. We have a lot of other programs in place. So I'm a nurse practitioner. We have an APP, professional governance, for our health system, but transplant is kind of their compensation is different than staff nursing. So staff nurses at our institution have clinical ladder, but we have not been able to get clinical ladder for our transplant coordinators and our transplant APPs. And I had a question for the California folks, if they feel like they've had better luck with the compensation because they're unionized. We are not union at our institution. So I have that question, and then also wondered if we should take a look at all the great comments in the chat box too. So I don't know if anyone, Megan or Annette, if they want to comment on that.
Yeah, I think I don't know that the union helped us, honestly, with doing the TC different categories, but honestly, I think it was because they were doing so much overtime and costing so much money. They were willing to look at it, and we kind of sold it to them. But they did have call for a bit too, so there was like an overlap. We had to kind of do one thing at once, so they were getting a stipend. And again, it didn't become worth it at some point, but it was a lot. It was between $300 and $500 a day to take call, in addition to their super high salary in California. But that was still desirable to them making time and a half. So
that makes sense.
I have raised my own hand, which is sort of.
I just wanted to comment though on kind of the practitioner piece too. So I think it was helpful just in that they did, prior to kind of creating the clinical ladder, that NP3 job type, or that job code existed. And so it did make it, from kind of a union standpoint, my understanding is easier to develop. It has, in speaking with our director of advanced practice, it sounds like it has been helpful just in that, in the prior to 2015, the funding came directly from each department, but versus being part of the union and having a set clinical ladder, it doesn't need to be department specific. It's through the advanced practice team too. So there is that kind of benefit that it's not department based necessarily.
That makes sense. Thank you.
Yeah. I would like to answer the question by Linda Oler in the chat. I'm trying to keep track of the chat also. And you ask about if there are any NPs in Europe. I would say that it differs between different European countries. And in my region, which is Scandinavia, we don't have any nurse practitioners, not in transplantation. We have a different educational system than you have in the States. But in other European countries like the UK, the Netherlands, Belgium, for example, Spain, there are advanced nurse practitioners focusing on transplantation. And I just would like to add like a Swedish or Scandinavian perspective on retention, because I agree with you that it is important to collaborate with the union and it's important to with a career ladder. But in my center, which is one of two centers doing heart and lung in Sweden, we also we have a great retention these days. And what we did was started a huge project focusing also on the content of the nursing work, sort of. So we launched a project about person-centered care, and we focused very much on continuity. So like you are a primary care nurse and you follow your transplant recipients, and we try to organize the nursing care so it really makes sense to the professionals. And what we learned from that experience is that when your practice sort of makes sense and you have a good structure, supportive organization, which really sort of guards or cares for the essence of nursing practice, it also helps retention a lot, not only the sort of formal hospital structures with career ladders and yeah, you know, at different educational levels. So I just wanted to add that perspective also.
Well, Anna, there was another question about organ call and
Yeah.
how transplant coordinators or nursing are involved in that, or if they are in the organ donation side in Europe, how that works.
Yeah, well, we have specific organ coordinators in each country, and we are collaborating in different regions. So like in Scandinavia, it's called Scandia Transplant, which organizes the Nordic countries and Iceland. And then it's Eurotransplant organizing the middle of Europe. And it's the Spanish organization and the French organization and a specific donation organization in the UK. So mainly we work in our region, European region, but of course we also collaborate cross borders if it's necessary. Yeah.
So are the transplant coordinators in your institution involved in the organ placement piece of things? So they are on call, for instance?
Yeah, they are on call 24/7.
Okay.
Yeah.
Great, thank you. I did want to just mention there's a lot of conversation about certification in transplant and whether that's required or not. And there seems to be a lot of different ideas around that. Some require, some don't, some give a stipend. I know for us, it's a condition, and it looks like there's at least one or two other centers where it's a condition to move up in the ladder. We don't require it because when we moved away from requiring it upon hiring, we used to require it within 1 year. And I think you have a coordinator trying to learn and onboard, which is a big lift in and of itself. And then you're asking them to also get certified as well. And I think it's a lot to ask. So we do a 3%, they get a 3% raise for getting their certification. And it is a condition to move up the ladder. And then you get, like Annette mentioned, the raises that go along with ladder progression, which, you know, it's a monetary incentive to want to do that. And I think it's just, you know, a condition of participating in the ladder. But everybody has their different approaches to that. But I do think it's helpful to not force people to take that on too early or when they're not ready, when they're still trying. As Paul said, everybody learns at their own pace, and you have to be mindful of that, and that could be overwhelming for some people. But I just wanted to throw that out there because there was a lot of discussion about that in the chat.
And I have a question for you, Paul, because you mentioned in your presentation a lot about mentorship and the importance of mentorship. And I was wondering if you could elaborate a little bit more on that, because I'm also of the opinion that mentorship is crucial, but maybe a little bit underestimated, the importance of mentorship in healthcare and specifically in nursing, and also the fact that it's important with role models, and mentorship is not necessarily equal to role models, I think, but I'm very well aware of the importance of good role models. So I was wondering if you could share some thoughts about that with the rest of us.
Yeah, thank you so much, Anna. So I think that mentorship is really invaluable. And one of the reasons, and this goes back to Benner's theory, and you know, she states that one of the things that makes allows people to progress along the continuum is experiences. And that's not something that you can just instill into somebody through a 6-month orientation process or however long it takes to sign off the competency. You're not going to be able to instill those experiences. So by pairing them with pairing a newer employee and making sure that they have somebody who they can reach out to that has the experiences, that's doing the same role as them. We're allowing them to essentially tap into somebody else's experiences to progress them further along that continuum. And I think that that's a lot of it. And then I also really truly believe that the relationship building is huge. By role modeling that communication, we can eliminate so many errors. As we all know, miscommunication is the number one cause of medical errors. And having somebody who has had all of that experience and developed effective ways to communicate with the cardiac surgeons, the inpatient APP cohort, the cardiologist, the organ placement procurement team, that all requires specific knowledge and an understanding of the best way to communicate with them. And so rather than learning that by themselves, pairing with that mentor helps to expedite that process.
Yeah, great. And I see Meg, you have raised your hand, please.
Meg, you're muted.
Thank you. I just wanted to ask Paul a follow-up question. I think a lot of times at ISHLT, especially through Nursing Allied Health, the question always comes up, can you share your competencies? What are you using? And I think oftentimes we think, gosh, shouldn't there be a kind of standard that we're all working off? And every center is different and we all have different roles at different centers. But what are your thoughts on having a NACO core competency or, you know, an ITNS core competency that we can put together, have a standard, and then, you know, obviously depending on your center and the specific role, you adjust for that?
I think that a core competency is really good because it allows to make sure that we're not missing anything. Because as we're going through these competencies, there's a good chance that things are going to be missed. I do firmly believe that there should be a lot of additions and your complicated workflows, whether or not it's a core competency of the skill, but a complicated workflow really needs to be part of that competency as well to make sure you're gathering that. And that would all vary from center to center, but there's a definite shared work that we all do. And so collating that and giving everybody a starting place, I think would be really interesting.
Right.
Thank you.
So there are only 2 minutes left of this wonderful and engaging webinar, and I would like to hand over to Angela for maybe a conclusion.
Yes, thank you so much, Anna. I just want to say I see a comment in the chat from Donna that NACO has just formed a committee to update core competencies, so there may be more to come on that. And then I also wanted to just throw out for all of us, you know, that was very early on, but Victoria mentioned that it would be really great if we organized a mentorship club that would just serve as a platform for professional connection and networking of transplant professionals. And I know there are a lot out there, but this would be, a key thing to think about. I think this was a great discussion. We're 1 minute to the end and we might get cut off. So I just want to thank everyone for joining us and for our amazing moderators and speakers. We really appreciate it. It was a really engaging session. So thank you, everyone. Enjoy your afternoon, evening, or night, as it may be. Take care.